Welcome to Weekly Neurology Deep Dive. I must explicitly state that this program is for educational purposes only, has no commercial goals, and is solely a summary. You are highly recommended to read the full paper we are exploring today. We are doing a deep dive into the paper titled Sleep Neurology, Pearls and Pitfalls by authors Adenin, Perez Carbonell, and Lichtiner.
Well, for neurologists who are short on time, I will provide a concise and practical summary of this paper right at the beginning. First, cognitive behavioral therapy for insomnia is the first-line treatment for chronic insomnia. Second, the multiple sleep latency test has high false positive rates and requires strict clinical correlation. Third, polysomnography is essential for atypical parasomnias and rapid eye movement sleep behavior disorder, but not routine non-rapid eye movement parasomnias. Fourth, dopamine agonists are no longer first-line therapy for restless leg syndrome due to high augmentation risks.
So when you see a patient in your neurology clinic and their primary complaint is an inability to sleep, the immediate reflex is to label the problem as insomnia. I mean, taking that symptom at face value is a dangerous clinical trap. I compare it to a patient walking into your clinic with facial pain, and you immediately label every single instance of neurological face pain a migraine. Just because a patient cannot sleep does not mean they have primary insomnia. You have to question the label itself before you write a prescription.
Exactly. True chronic insomnia affects about 10% of adults in the general population. But when you look at neurological populations, that prevalence skyrockets. In your patients with migraine, the rate of insomnia is about 70%. In your patients with multiple sclerosis, it is about 40 to 50%.
With numbers that high, it is easy to see why you might just assume primary insomnia is the culprit.
Absolutely. Because the numbers are so high, it is an easy trap. When a patient reports poor sleep, you must carefully distinguish between true excessive daytime sleepiness and fatigue. These sound similar to a patient, but they are biologically distinct.
I see. So how should a neurologist rapidly differentiate the two in a standard clinical interview?
Well, fatigue is the physical or mental exhaustion that makes sustaining voluntary activities difficult. Your patient will say they feel entirely drained of energy. Excessive daytime sleepiness, on the other hand, is the biological inability to stay awake, resulting in unintended lapses into sleep. Pure insomnia rarely causes true excessive daytime sleepiness.
That makes perfect sense. If your patient is falling asleep uncontrollably during the day, you must look beyond a simple insomnia diagnosis. That distinction points directly to underlying comorbidities that masquerade as primary insomnia. Obstructive sleep apnea is highly prevalent here, presenting in about 40% of insomnia patients.
Indeed. And in many clinics, you might be tempted to order a home sleep apnea test to rule this out quickly.
But think about the mechanics of that test. If your patient is lying awake for most of the night due to severe hyperarousal, the testing equipment cannot capture adequate data during actual sleep.
Precisely. Because the device only records breathing events, it cannot distinguish between a patient who is awake and breathing normally and a patient who is actually asleep. Because of that exact scenario, home sleep apnea tests have an estimated false negative rate of up to about 17% in this specific population.
Which means you could easily miss a massive physiological driver of their sleep disruption. You also have to consider the timing of sleep, which brings us to the circadian rhythm. A misaligned internal clock frequently presents as an insomnia complaint, doesn't it?
It certainly does. Circadian rhythm sleep disorders affect about 10% of the population. Strikingly, these circadian issues are misdiagnosed as insomnia about 22% of the time.
Let us unpack how that misdiagnosis happens. In delayed sleep phase disorder, the patient simply cannot fall asleep until very late, perhaps 2 or 3 in the morning, and they cannot wake up early.
Exactly, because their endogenous melatonin release is phase shifted to occur much later in the night. If their lifestyle or job requires a 7 in the morning wake time, they suffer chronic sleep deprivation.
And to you, the clinician, this looks identical to sleep onset insomnia. The patient lies in bed for 3 hours trying to sleep. But the underlying pathology is a phase-shifted circadian rhythm, not an inability to generate sleep itself.
Absolutely. If you allow them to sleep on their own delayed schedule, their sleep architecture is completely normal.
So this changes our entire treatment approach. The instinct in the clinic is often to immediately write a prescription for a sedative. However, the paper emphasizes that cognitive behavioral therapy for insomnia is the definitive first-line treatment.
Exactly. Rather than suppressing the nervous system chemically, this therapy utilizes sleep restriction and sleep compression.
By deliberately restricting the time the patient is allowed to spend in bed, you force their brain to build a massive homeostatic sleep pressure and accumulation of adenosine.
Precisely. That physiological pressure eventually becomes so strong that it overrides the psychological hyperarousal, keeping the patient awake.
Hmm.
Cognitive behavioral therapy for insomnia yields an about 60 to 80% response rate and provides long-term benefits that outlast the treatment period because it actually rewires the patient's association with the bed.
Of course, we must acknowledge accessibility issues and instances where behavioral therapy fails. When pharmacotherapy is necessary, the field has advanced significantly with the introduction of daridorexant, a dual orexin receptor antagonist.
Well, by blocking the wake-promoting orexin pathways, it improves sleep onset and maintenance. It removes the chemical drive for wakefulness without causing the global central nervous system depression and respiratory suppression seen in older sedatives. In clinical experience, there is about 70% response rate to this medication.
You also have to watch out for the inappropriate use of older medications that might actually make the hyperarousal worse. A common mistake is prescribing mirtazapine at high doses for sleep.
Absolutely. Its sedating effects, which operate primarily through histamine receptor antagonism,
Yeah.
are maximal at low doses. At higher doses, its noradrenergic activity takes over.
And that creates alerting effects that actively worsen the patient's sleep, causing the exact opposite of the intended clinical outcome. Let us shift focus from patients who cannot sleep at night to those who cannot stay awake during the day. This is the realm of hypersomnolence.
Indeed. And this introduces a very tricky diagnostic area.
Our primary diagnostic tool in the clinic is the Multiple Sleep Latency Test. This test puts sensors on the patient and objectively times how fast they fall asleep and enter rapid eye movement sleep during a series of daytime naps. It feels like the definitive, objective gold standard for diagnosing narcolepsy. I struggle to see how putting a clock on a physiological process could lead a neurologist astray.
Well, relying on the multiple sleep latency test as an infallible gold standard is a profound pitfall. It has a massive false positive rate. Even when you apply strict diagnostic criteria, such as a mean sleep latency of less than 5 minutes, up to about 30% of positive cases do not actually have narcolepsy.
Wait, really? Up to about 30% are false positives.
Yes, because the test is highly vulnerable to the patient's prior sleep habits. If your patient has chronic, behaviorally induced insufficient sleep, meaning they only sleep 5 hours a night for months, their brain becomes starved for rapid eye movement sleep.
So when you put them in a quiet room for a daytime nap test, their brain will naturally enter rapid eye movement sleep very quickly. To the monitoring equipment, this mimics narcolepsy perfectly.
Exactly. Therefore, it is an absolute necessity to perform 2 weeks of actigraphy prior to testing. You have to objectively prove the patient is achieving adequate sleep duration at home before you subject them to daytime nap testing.
If the physiological nap test is that vulnerable to false positives, you might instinctively reach for a molecular biomarker to give you a definitive answer. You can measure cerebrospinal fluid orexin levels to confirm the loss of wake-promoting neurons in the lateral hypothalamus.
You can, and a cerebrospinal fluid orexin level of less than 110 picograms per milliliter confirms a diagnosis of narcolepsy type 1. But even this biomarker has blind spots.
How so?
Well, normal orexin levels are seen in about 5% of typical cases of narcolepsy with cataplexy. This occurs because the destruction of the orexin-producing neurons might be highly localized or partial. This leaves enough residual peptide in the spinal fluid to register as normal on a test, even though the signaling in the brain is functionally severely impaired. Furthermore, normal levels absolutely do not rule out narcolepsy type 2.
I see. So if the fluid test has gaps, you might turn to genetic markers. Human leukocyte antigen testing, specifically looking for the DQB106.02 allele, is frequently discussed when evaluating hypersomnolence. Does that genetic marker give us the hard yes or no we need in the clinic?
Not at all. That allele is present in about 95 to 99% of patients with narcolepsy type 1. The major limitation is its lack of specificity.
Because it appears in the healthy population as well, correct?
Precisely. This exact same genetic marker is found in up to about 38% of the normal, healthy population. Its presence simply indicates a genetic susceptibility, not the presence of the disease itself. Because so many healthy people carry it, finding the allele does not confirm narcolepsy, and its absence only helps to rule out narcolepsy type 1. This severely limits its routine diagnostic utility for you in the clinic.
The therapeutic landscape for treating this hypersomnolence is undergoing a major shift. For years, you likely relied on traditional agents like modafinil and sodium oxybate. But sodium oxybate carries a heavy burden for the patient. About 25% of patients stop taking it entirely due to severe side effects like nausea, mood swings, and even psychosis.
And that high discontinuation rate is exactly why the newer pharmacological agents are critical for your practice. Pitolisant functions as a histamine H3 receptor inverse agonist. It enhances wakefulness by increasing histaminergic transmission in the brain, avoiding the massive dopamine spikes and abuse potential associated with traditional stimulants.
That is a significant pharmacological pivot.
It is. Additionally, solriamfetol acts as a targeted norepinephrine dopamine reuptake inhibitor. But the most important emerging frontier lies in orexin agonists.
Since narcolepsy type 1 is fundamentally an orexin deficiency disorder caused by the loss of those hypothalamic neurons, directly replacing that signaling is the ultimate goal.
Absolutely. Drugs like oveporexton are currently in phase 3 trials. By directly agonizing the orexin receptors, the goal is to fundamentally stabilize the patient's fragile sleep-wake transitions, rather than just masking their severe sleepiness with heavy stimulants.
We must transition our focus from abnormalities of sleep timing and duration to abnormal physical behaviors that occur while the patient is actively in the sleep state. These are the parasomnias.
This is a fascinating area of sleep neurology.
It is. When examining non-rapid eye movement parasomnias, like sleepwalking or confusional arousals, I use the analogy of a computer trying to reboot while still running background programs. The brain gets caught in an incomplete transition between deep, slow-wave sleep and wakefulness.
I completely agree with that analogy. The motor cortex and the central pattern generators for movement are fully active, allowing the patient to walk or eat, but the conscious executive centers of the brain remain offline.
Because the patient is moving around unconsciously, if a patient presents to your clinic with a history of sleepwalking, your first instinct might be to immediately order a polysomnogram just to be safe and rule out a dangerous neurological event.
Well, routine polysomnography is not recommended for typical non-rapid eye movement parasomnias. These events are usually benign, easily diagnosed on a thorough clinical history, and a sleep study adds virtually no diagnostic value because the patient rarely performs the specific behavior during a single night in a sleep laboratory.
So when is polysomnography actually mandatory?
You must clearly identify the mandatory indications for polysomnography. You must scope the patient if there is any clinical suspicion of rapid eye movement sleep behavior disorder. Normal rapid eye movement sleep requires complete atonia or paralysis of the skeletal muscles driven by brainstem pathways.
And when those pathways degenerate, the patient enacts their dreams.
Exactly. This is crucial for a neurologist because dream enactment behavior is a major clinical herald for underlying alpha-synucleinopathies, such as Parkinson's disease or dementia with Lewy bodies. The damage to the brainstem sleep centers often precedes the motor symptoms of Parkinson's disease by years or even decades.
You also have to consider that physical behaviors during sleep might not be a sleep disorder at all. They could be seizures masquerading as parasomnias.
Indeed. Polysomnography is mandatory to evaluate for sleep-related hypermotor epilepsy. The behaviors during these seizures can be highly complex, involving thrashing or pedaling movements that mimic non-rapid eye movement parasomnias perfectly.
And our anatomical understanding of those seizures has evolved recently, hasn't it?
It absolutely has. While we historically thought these sleep-related seizures were almost entirely of frontal lobe in origin, recent monitoring shows that up to about 30% of these patients actually have extrafrontal seizure foci, such as in the temporal or insular cortex. Finally, any sync behaviors that are violent or cause injury to the patient or their bed partner mandate a full polysomnogram for both accurate diagnosis and forensic safety.
Returning to those non-rapid eye movement parasomnias, the paper notes an incredible physiological connection regarding comorbidities. Even if the parasomnia itself is benign, the underlying trigger forcing the brain into that incomplete transition state might be entirely treatable.
Exactly. About 30% of patients with non-rapid eye movement parasomnias have a comorbid sleep disorder, most frequently obstructive sleep apnea or periodic limb movement disorder.
So how do those comorbidities physically trigger the sleepwalking?
These comorbid conditions cause microarousals. When the patient stops breathing, the brain sends an emergency arousal signal. By abruptly fragmenting the sleep architecture, the apnea forces the brain out of deep, slow-wave sleep and into that incomplete transition state you described.
I see. So the apnea is the trigger pulling the lever on the sleepwalking.
Precisely. By simply treating the obstructive sleep apnea with positive airway pressure or treating the limb movements, you eliminate the sleep fragmentation. Without the microarousals, the sleepwalking parasomnia often resolves completely without ever needing targeted parasomnia medication.
Expanding on those sleep-related movements, we must examine restless legs syndrome. This area represents a major paradigm shift in treatment, one that causes profound iatrogenic harm if you ignore it in your practice. I compare the use of dopamine agonists for restless leg syndrome to using a high-interest credit card to pay off a mortgage.
That is a perfect way to look at it.
Using a drug like ropinirole completely fixes the immediate problem tonight, allowing the patient to sleep, but it guarantees a much more severe systemic crisis down the line because you are accumulating physiological debt.
Absolutely. That physiological debt manifests as a crisis known as augmentation. Historically, dopamine agonists like ropinirole and pramipexole were the definitive first-line therapies. But chronic exposure to these agents causes a paradoxical worsening of the disease over time.
Because by flooding the dopamine receptors, the brain responds by downregulating those receptors.
Precisely. And then the patient's symptoms become more severe. The urge to move starts earlier in the afternoon rather than just at bedtime, and the irresistible sensory discomfort spreads from the legs to the arms and the trunk. Dopamine agonists cause augmentation in about 30 to 70% of patients after 10 years of continuous use.
That is a staggering rate of iatrogenic harm caused directly by the medical intervention. Because of that severe specific risk profile, the American Academy of Sleep Medicine no longer recommends dopamine agonists as first-line therapy. The entire standard of care has been rewritten for how you approach this in the clinic.
Exactly. Before initiating any targeted pharmacological therapy for restless legs, there's a mandatory first step you must perform: checking the patient's iron stores.
Why is iron the absolute first step?
Because iron is an essential cofactor for tyrosine hydroxylase, which is the rate-limiting enzyme in dopamine synthesis within the central nervous system. Brain iron deficiency is a primary driver of the underlying pathophysiology of restless leg syndrome.
So serum ferritin must be checked and strictly maintained above 75 to 100 micrograms per liter.
Absolutely. If the patient falls below that threshold, oral or intravenous iron supplementation is the required initial treatment.
If you verify that the iron stores are replete and the patient still requires symptom management to sleep, you have to choose a non-dopaminergic pathway.
Indeed. The first-line treatments are now the alpha-2 delta ligands, specifically gabapentin and pregabalin. These agents bind to voltage-gated calcium channels in the central nervous system.
By doing so, they reduce the release of excitatory neurotransmitters, effectively calming the sensory discomfort and improving sleep continuity without touching the dopamine system.
Precisely, completely avoiding the risk of augmentation. For patients who are refractory to these medications, or for those who are going through the grueling, highly uncomfortable process of withdrawing from dopamine agonists to reverse their severe augmentation, you must turn to low-dose opioids.
Because the endogenous opioid system interacts closely with the basal ganglia to suppress the urge to move.
Exactly. Prolonged release oxycodone naloxone or buprenorphine may be used as effective bridging therapies during withdrawal or as long-term solutions in severe intractable cases.
That structural shift in managing restless leg syndrome perfectly captures the evolving nature of this field. You have to constantly update your practices to avoid causing long-term harm to the delicate sleep architecture of your patients.
Indeed. And to reinforce these critical updates for your daily practice, I will repeat the practical summary exactly as stated at the beginning for the busy neurologist. First, cognitive behavioral therapy for insomnia is the first-line treatment for chronic insomnia. Second, the multiple sleep latency test has high false positive rates and requires strict clinical correlation. Third, polysomnography is essential for atypical parasomnias and rapid eye movement sleep behavior disorder, but not routine, non-rapid eye movement parasomnias. Fourth, dopamine agonists are no longer first-line therapy for restless leg syndrome due to high augmentation risks.
As neurology moves away from using blunt sedatives that suppress respiration and dopamine agonists that cause receptor downregulation and moves toward precision therapies like targeted orexin agonists and behavioral circadian entrainment, we face a paradigm shift. Will the future of sleep medicine rely less on forcing the brain into an artificial state of unconsciousness and rely more on precisely calibrating the brain's internal clock? That is a question you will have to answer in your clinic over the next decade of neurological practice.